Okay. So we will start the another case-based discussion as requested by you people. So it's my pleasure to introduce today's speaker, Dr. Fahim Samsuddin, another one of the best PeMSAA alumni. We worked together when I was SR. Fahim was the registrar in the Colombo professorial unit. Just like Inasha, who did the Obs and Gynae, the last lecture in PeMSAA. So we were ruling the Colombo professorial unit. The PeMSAA graduates were ruling the Colombo profit. I think Fahim will agree. Yeah, so Fahim is currently a consultant obstetrician and gynecologist from the base hospital Valaichchenai. He returned recently from Australia. So he's a very young gynecologist and he's fresh from his overseas training. And he carries the latest knowledge, up-to-date knowledge. And what we discussed and what we planned, as we planned earlier, this is basically to cater you people, the medical students. So you can ask any question, and this again is a technically relevant approach. So what I will be doing is, again, this is your request. The request came from the students, how to approach the clinical scenario in obstetrics. If a fundal height is larger than expected or larger than the period of guess, right? So it's a clinical scenario you encounter monthly in your long case, and it may be questioned as well, and you do get MCQs from
Thank you very much for wonderful to interact with me, track on junior. In my so as you said, in much fun in the maternity unit, maternity field, while I was a researcher and you are working in as a senior registrar with the NOSHA and some other graduates. So I also have to thank PeMSAA for screen. So let's see the screen. Can you see the screen now?
Yeah, we can see.
Yeah, thank you. Okay, so basically we are going to discuss about the simple mode of amenorrhea, how we clear this kind of a case. So before going for formal overview, I would like to tell what are the contents we are going to discuss. Basically, first thing is definition. We should know about the definition to say it's a fundus is more than POA. So, and second thing will be how they are present in an exam. They can present in a various ways. So I'm going to discuss you about that. And then what are the basic causes for the symphysis fundal height larger than guess. And also how to manage basically. And then I will go for a few cases as well as few MCQs you may encounter in your examinations. So definition wise, so symphysis fundus is basically symphysis fundus means uppermost part of the uterine fundus to the upper part of the symphysis. If measurement in centimeters, we usually measure from 24 weeks onwards, and we say it is abnormal if it is more than more or less than 2 centimeters up to 37 weeks, and after 37 weeks we usually say it should be plus or minus 3 centimeters. So as we discussed in large fundus, it should be plus 2 centimeters up to 37 weeks and plus 3 centimeters after 37 weeks. Sensitivity-wise, it's just 35%, but it says serial measurements of serial fundal heights and charting on a customized chart increases the sensitivity. Why we use? Because it's less invasive, cost effective, as well as we need less technical expertise. So even a midwife can do this job. So it's basically a very cost effective tool. So how they present at examinations? So basically first thing is they can present as their first complaint. So mothers basically will say, I have a larger baby, or my fluid volume is high. Easy to analyze because you have to analyze the given complaint. Second presentation is as a complication of their first complaint. So mother will say something like, I am having diabetes, or I came for a early delivery or something like that. Then you have to analyze what the reason and what is the large funduses. Anyone willing to answer for the causes? Causes for the large fundus.
Polyhydramnios.
Good. What else?
Wrong dates.
Wrong dates. Yes, exactly. What else?
Multiple pregnancies.
Good. Multiple pregnancies. Anything else?
Fibroids complicating pregnancy.
Good. Yes. Anything else?
Macrosomia, sir.
Yes. Macrosomia. Yes. That should be the first cause, you should say. Yeah. Anything else? Okay. So these are the basically causes. First thing is the fetal macrosomia. Fetal macrosomia could be due to wrong dates, could be a genetical issue, maternal obesity, diabetes, multiparity, or with a past history of macrosomia, or it could be the male sex. And then second cause is polyhydramnios. And don't forget the causes also, because you may not enter the exams like this, because usually detect them very early as we have ultrasound scan now. But in exams like sometimes examiner may ask you what are the causes, you can mention it. Or MCQs, you will get these things. Smaller pregnancy, you will have higher funds. But now it is very rare presentation because doing dating ultrasound for all the mothers. And what are the, so how we going to analyze such a patient comes to and says, they says my fundus is larger than dates or something like that. In history, what are the questions you are basically going to ask? Any answers? As this is a case-based discussion, I would like to know your answers. In history, what are the specific questions you want to ask? I'll give you first one. In past obstetric history, you are specifically asking about the parity as well as the birth weight of previous babies, because those are risk factors for a macrosomic baby. And then in first trimester, what are the specific things you are going to ask? Mother says she is having a larger baby or something like that.
The dating scans.
Good. Anything else?
fever at the first trimester?
Sorry?
Whether she has got fever or with rash or some infection.
Any infective features. Okay. Anything else? Commoners, but commonly we are in first trimester for all the mothers in.
Yes.
And then menstrual period, whether some mothers we are doing postprandial blood sugars, and some mothers we are doing specifically OGTTs, like mothers who have a higher risk of having chronic diabetes. And then what else?
Hyperemesis suggestive of H mode.
Good. Yeah. You have to ask about the hyperemesis. Anything else?
A scan showing multiple pregnancies.
Good. I'm missing one thing. That's why I'm still asking. Anyway, I'll go for that. Blood group and RH. Why? Anyone can say why blood group and RH is important? If sorry?
Eye drops.
Yes, good. Because of that, we need to know about the blood group, RH, and whether if she's negative, whether she has developed any antibodies. And then if she developed any fever or something, like whether she undergone kind of a specific investigation to screen any infection or screen. We are not routinely doing, but if she had any fever or first trimester infection, whether she had these tests done or not. Right? And second trimester, what are things you are going to specifically ask?
Results of the anomaly scan, sir.
Yes, good. Why?
GI problems like polyhydramnios and then large.
Yeah. Any anomaly causing fallopian difficulties can cause polyhydramnios. That is one thing. Another thing is hydrocephalus. And also we can find hydrops features also. As well as what is the other thing in second trimester you want to ask?
OGTT.
Yes, good. Again, the blood sugar assessment. And also don't forget about the fetal sex, because the male babies are tend to be larger. So you have to show that specific. What are things you are going to ask? Anything else you want to ask? History? And thinking about a simplicity far more than larger fundus? Anything in the past medical you want to ask? Again, you can ask about the diabetes. Whether she had chronic diabetes, whether she's a non-mother with a chronic diabetes, what are the treatments she had? And also you can ask about whether mother had RH immunization prior to this pregnancy. So those are things you should ask in the past medical history. And then past gynecological history, because if you are suspecting fibroid or something like that, you have to ask about the past gynecology history, what has happened, any treatments done, those things you have to, not in detail, but basically you have to question them, right? Okay. Now we'll move to specific courses. If we found any specific courses, what are things you need to ask in your history? If previous large baby, what are things you are going to history? Obstetric history, previous baby also 4 kilograms. So what are things you are asking additionally?
The mode of delivery complications.
Yeah. Mode of delivery as well as complication encountered during delivery. Because previous large baby means there's increased risk of this time having a large baby, and also she's having increased risk of those complications too. And also sometimes, suppose if mother had a kind of a 4th degree tear with a large baby last time, we will not go ahead and do the vaginal delivery. This time we will usually offer them a cesarean section. So management is changed because of a baby as well as associated complication in previous pregnancy, right? And also don't forget about the neonatal complications also, like if you had a previous large babies tend to have some particular neonatal complications. So you have to ask those things also, right? So what are the neonatal complications large babies can have, macrosomic babies?
Neonatal hypoglycemia. Hypo.
Anything else?
Shoulder dystocia.
Yeah. Neonatal complication, yes. Shoulder, you can say complications associated with shoulder disorder such as brachial pain, all those things. Right. Anything else? Okay, that is your homework. About the neonatal complication related to macrosome babies, right? Okay, so the second was, if you found in history whether she's an early diabetes, gestational diabetes, or chronic diabetes mellitus, what are things you are going to ask? History, mother says she's having, whether her blood sugars, like early first trimester blood sugars are high, or she's a known mother with chronic diabetes mellitus. What are things you are going to ask?
Blood sugar control, HbA1c.
Good. Anything else?
What drugs she's on now?
Yeah. What are the treatments she's on now? Anything else?
Screen of pregnancy.
It's good. Screen for macrovascular and microvascular complications. So you have to ask about the questions related to blood sugar treatment, complications, like complications, as I said, microvascular and macrovascular complications, and fetal complication. Don't, when you ask them as 2 units, and so these are the medical complications I'm going to ask, and fetal. Fetal is obviously what we need to know, particular case, whether baby is affected with, whether baby is having polyhydramnios with macrosomes. No, don't, so you're going to ask those things also. Okay, if RA choice immunization, what are the questions, specification you have to ask from the mother? Question is not common questions. It's better to know basic idea about the patient and what monitoring are doing in the pregnancy, those things, right? So if basically you have to ask, yeah, how frequently mother monitor and whether titers have gone up or not, and as well as monitoring of the fetal anemia with the ultrasound scan, right? So things you have to ask through from the mother, right? If mother does that during the examination process, mother says she had a diffuse first infection and some tests came massive. Other specific thing you are going to. This is also not a common encounter you are going to encounter, but still better. Infection, right? And then if any pelvic masses during in his fibroid or like that, what are things you are going to ask? Again, you are going to ask about when it was detected, what have size of the fibroid, any symptoms related to fibroid such as pain, because why in the pregnancy they can have what kind of what we call that about that and then now we are moving to examination. In general examination, what are things you are going to look into? General examination with related to a larger fundus. Obesity is a one cause for macrosomic babies, so definitely you are going to look into mother's BMI, right? And if any specific causes like mother given like chronic diabetes, then you have assess features of macro and microvascular complication. Even though you are strict, if you get a case with a chronic medical condition, you have to show the examiners that you are thorough with those particular examination things. So you have to look for mothers, macro and microvascular complication, but not in detail. Just show the examiner that you are looking into those things, right? Because some examiners will get annoyed if you are doing medicine type of examination on obstetric patient. Just show that you are looking like very briefly these things, right? And then on the abdomen, you have to look at the features of forward distension. So what is the forward distension during inspection? What are the features of forward distension?
Shiny, more stretch marks.
Good. Stretch marks, shining abdomen. Right. Anything else? Then during the palpation, you are finding sympathy spondylitis larger than the days. So you are going to come that. And then the specific, like not specific, but if mother is having polyhydramnios, we are eliciting some signs. What are the signs?
Difficulty to feel the fetus.
Good. Anything else? So you can say hardly palpable. Okay. Anything else? Any other sign you are going to elicit if mother is having polyhydramnios? Most of the examiners get impressed when you do that. Any one of you demonstrated fluid trill on a polyhydramnios mother? Anyone said to do that? To demonstrate fluid trill? So it's the one thing you can do, right? So you can ask if there's a chaperone, ask the chaperone to keep the hand on the middle of the abdomen and elicit the fluid trill from your one hand from the other hand. Or you can ask the examiner, but never ask the patient to keep their hands, right? Some examiners don't like asking the patient to keep the hand on tummy. So you can demonstrate the fluid trill and show that increased fluid volume in the uterus, right? And then features of multiple pregnancy you can demonstrate. How you say it's a multiple pregnancy? By saying you can feel multiple fetal walls, right? So those things you have to see if you examine a multiple pregnancy. And also, suppose in a Polyhydramnios case, you can't feel the fetal pole much. Some patients, we can't feel the fetal poles at all. In those cases, you should try to examine fetal eye and everything. But if it is very difficult, you should say, it's very difficult to feel the fetal poles. So I would like to go ahead with ultrasound scan to fetal eye. Its movements, its consistency, its margins and everything, driving, right? Okay, management. So what are the components of obstetric management? Any of these components? So you did the examination, you did the you did the history, you did the examination, and what are the other components in management unit?
Investigations to assess the well-being of the fetus.
Okay.
The condition. Optimizing the mother's conditions related to
Your treatment. Yeah. Anything else?
The more time of delivery and place of delivery.
Good. Okay, I'll show you how I do it. Of the pregnant and to complete manipulation could be fetal. So this covers all the investigation time. Suppose it's a GDM patient, I need OGT to diagnose, to assess the severity of the blood sugar series, to monitor the maternal and fetal complications, treatment. What are the GM we have? So we're going to start the treatment, whether she on medical nutrition therapy, whether she on metformin, whether she on insulin. Sometimes for cases like idiopathic polyhydramnios, we don't have treatment. Then you are not going to discuss about the treatment, right? And then, as previous said, time of delivery. So your gas at you are delivered period of gestation. From there, because he will shoot the questions, he will drag wherever he wants. But if you go along the management downward from here, examiner have no time to ask question. He will have time. So when you finish about the place of delivery, go interpartum management. Right? Never forget that. Any specific thing in a GDM, you say, I would monitor the mother's blood sugars. Never, and then don't think to management. Go for the immediate and long-term postpartum management and finish management by saying the contraception advice, right? So this is how I answer, or this is how I did my obstetric cases, right? So start from the case, like right? So the first case, 32-year-old in her second pregnancy, now 32 weeks, and mother directly says she's having a large baby. Okay, so what are things you going to ask in the history? I will answer. So I have given a basic history of the mother. Think that I am the mother. I will answer your questions. You can ask for me.
When did you find out that the baby is large?
Sorry?
When did you find out the baby is large? At what week?
Okay. Mother says at 2 weeks ago, 30 weeks.
What is your last menstrual period and when was and what does the dating scan mention?
Okay.
The dates.
She's having a regular menstruation. So her calculated POA as well as the dating scan EDD both are compatible. So she's having a correct dates.
Were the booking visit and the 26-week OGTT show any abnormalities?
Booking visit PBBS is normal. And 28-week OGTT is this value.
Past history of macrosomic baby.
I would try to first OG findings, please. The person.
The first hour and second hour are both high, as well as the high, and that indicates.
So now you know okay. Any other questions?
The rate of the
Yes. Birthday 2.
Started on the OG.
Yes.
Did she blood sugar, and if so, what are the values of that?
Admission ward, and she can't remember the values, but after looking at the blood sugar values, they started insulin.
ultrasound scans been planned or done, and what were the findings?
Had her ultrasound scan at 30 weeks. And again, she had an ultrasound scan at 32 weeks on this admission, right? This baby will use anything else? Okay, on examination, what are things you are looking for? Examination, any question?
For distension and this FH.
Fundal height, that is the main thing you're going to see, right? So you're going to examine the symphysis fundal height. And don't forget to assess the light volume also, because sometimes with the GDM, you can have both macrosomia as well as the increased polyhydramnios. So you have to specifically look into those two things. Other than that, general examination you have to comment, right? So symphysis fundal height is 31 centimeter. About that for me. 37 centimeter. Normal?
It's more than the 2 centimeter from the POA,
so it is larger, right? Okay. Now we'll move to management until delivery. Now she is 32 weeks on diet control, metformin, and just started with insulin. So how are you going to manage?
I would like to assess blood sugar control with, if possible, with the daily blood sugar series. If not, 2 weekly blood sugar series. Though she is on insulin, I would like to check with a 6-point blood sugar series.
6-point blood sugar series. Okay, good. So ideally, we should ask them to buy a glucometer and do a blood sugar series daily. If it is difficult, depend on the severity or depend on the control, we can do intermittent blood sugar assessment, blood sugar series assessment, right? Don't say 2 weekly. You should say depend on her blood sugar control. We should decide the period. If it is well controlled, then every 2 weeks. But if it's a poorly controlled, we may do it like every 3rd day or every weekly, something like that. Right. So that is the monitoring of our blood sugars. But it's
I want to plan a mode of fetal surveillance, sir. I mean, via ultrasound scan, serial ultrasound scan, biophysical profiles.
Biophysical profile. What do you mean by biophysical profile?
The scans and the Doppler studies.
Yes, biophysical profile. Now we usually don't use that. You can say ultrasound scan, right? Ultrasound scan to assess the growth and the volume. And Doppler studies are not always necessary unless you find some abnormality. So we usually don't do Doppler studies unless you find some abnormality. So you usually do growth and volume assessment. So how frequently you are going to do it? In exam, you can say anything between 2 to 4 weeks, right? Some examiners will agree with the 2 weeks, some examiners will agree with the 4 weeks, but not before 2 weeks or not after 4 weeks. So you can give an answer. You can go into serial growth monitoring between 2 to 4 weeks intervals, right? Anything else in your management until delivery?
And in the time and mode of delivery, in this case, she's uncomplicated. The fetus, there's no compromise. We can wait until 37 weeks. 37 to 39 weeks.
So the ultrasound scan, I forget to say about the ultrasound scan findings. These are the ultrasound scan findings. Estimated fetal weight and abdominal circumference both lie as the 93rd centile, the babies, and AF5 16. So comment about that finding for me. Because in exam, when you said about some investigation, sometimes examiner gives the investigation to your hand. So you should know how to interpret it. All the parameters are in the normal range. And these are the things important highlighted.
The abdominal circumference and estimated fetal weight indicator in the 93rd centile, that is that's indicator macrosomic baby. The amniotic fluid index is normal, sir.
Good, very good. Yeah. So the baby is macrosomic but not affected with polyhydramnios, right? Okay. So we'll go for the treatment. Treatment you discuss medical nutrition therapy, metformin and insulin, right? And then mode of delivery. So what are the mode of delivery you are going to discuss? How are you going to discuss the mode of delivery?
You want to know her, she already has one child. You want to know the method, how it,
very good.
That baby is delivered.
Very good. It's a vaginal delivery.
And depending on that, because of her pregnancy is complicated with gestational diabetes mellitus and macrosomia, I like to deliver at 37 if it is done by LSES, or 38 if it is 38 if it is normal vaginal delivery.
What is a normal vaginal delivery?
Not normal vaginal delivery. Induction of labor and vaginal delivery.
Okay. You can say vaginal delivery. Never say normal, because like 99% deliveries we do in Sri Lanka, they are not normal, right? Normal delivery, there are a lot of like requirement to say it is a normal delivery. So read about that. What is a normal delivery? So you can say about the vaginal delivery. So usually mode of delivery, if mother had a delivery, you will allow go for a spontaneous. But if mother's not had a preterm delivery, you usually should deliver between 37 weeks to 38.6 days. That means between 37 to 39 weeks. So your delivery. So usually mothers will not go for spontaneous vaginal delivery between 37 to 39 weeks. That means mode of delivery should be induction of labor or cesarean section, right? So decision of induction of labor versus cesarean section also again depend on other indicators. One thing is, suppose if baby's weight is 4.7 kilos, will you go for induction?
No.
I mean, that not the weight now at 37 weeks. At 37 weeks, baby's weight is 4.7 kilos. You are not going for induction, then what you are going to go for? You are going for a prophylactic cesarean section. Why?
Possible shoulder distortion during delivery.
Good.
Maternal complications like degree tears.
Yes, very good. So that's the reason we are going for prophylactic seizures. If this mother doesn't had GDM and baby's weight is 4.7 kilos, then what?
Still we go for the prophylactic cesarean sections.
Yeah. It's like this. According to guidelines, no. Because if no GD, no diabetes, you can go up to 5 kilos. But that guidelines come from Europe, not from Sri Lanka, right? So in Sri Lanka, what you have to see is induction of labor is still a possibility, but there's a higher chance of she's going to have shoulder dystocia, baby's going to have shoulder dystocia and related complication, mother's going to have a perineal tears. So you should say you like to take a senior opinion, as well as you're going to discuss this with mother and offer the cesarean section, right? Something like that you have to answer. You don't straight away say you are going for a CIS or something like, always say this kind of a tricky situations. You are going to discuss this with seniors and if possible take expert opinion, and you are going to discuss this possible things with the mother and offer the both options and support her decision, something like that, right? Okay. So we discussed about the time of delivery and mode of delivery. Why 37 to 39 in this mother?
GDM can cause intrauterine death at any time without ultrasound features.
So, because of the increased risk of stillbirth, we are going to deliver. Suppose this mother doesn't have macrosomia and this mother is only on diet control. In that case, still are we going to deliver 37 to 39?
Depends on the sugar also.
Well controlled. That's why she's on diet control. Otherwise, you put something else. No?
Yeah.
Yes.
Yes.
Well controlled, normal growth, normal like volume, on diet control. Then what is the time of delivery?
Up to 40 weeks we can look.
Yeah. So usually, especially this kind of a GDM case, you have to say about few things. One thing is the her blood sugar control. If she's on insulin, means her blood sugar control is poor. That's why we put on to her insulin, so that she's in a poor control. Therefore, her risk of stillbirth are higher than a mother who's on a diet control. Therefore, you are going to deliver between 37 to 39. And in metformin means it's like control is poor, but not severe like mother who's on insulin. Then those mothers we usually tend to deliver between 39 to 40. Mothers who are on dietary control with no fetal complication, they can wait up to 40 weeks, right? So that's to answer. In the yes, it's between 37 to 39. That's because two reasons. One thing is she's on insulin. Second thing is already baby is affected, right? Okay. Place of delivery. So what is the place of delivery?
Tertiary care unit.
Tertiary care unit. So qualify me the answer of tertiary care unit. How many tertiary care units in Sri Lanka? You should say what are the things you are expecting in that particular unit. Then only examiner will be impressed that you are specifically saying those things instead of just saying the tertiary care. I know in tertiary care centers we can deliver it, but our mothers who are having these issues, like there are a lot of GDM prevalence is very high in Sri Lanka, like 18%. So if you are going to send those mothers to tertiary care center, practically problematic one. So what are the things you are expecting saying we are going to deal in this month? Never just say the tertiary care center. You should qualify your answer.
There should be a neonatologist to look for the baby, and there should be experienced obstetrician and theater facilities to manage postpartum hemorrhage.
Theater facility to manage postpartum hemorrhage. Only postpartum hemorrhage you are expecting? So don't say about what is the reason, but you say yes, you need theater facilities, and what else you want? You said obstetrician-led unit, and there should be a pediatrician or neonatologist. And you said there should be theater. What else? There are 2 more requirements. Blood bank and neonatal intensive care unit, right? And also it's better there should be a consultant anesthetist also, right? Because in a macrosomia, it's not just PPH. There could be a risk of cesarean section. With the Caesar, there could be a risk of PPH. Then you have to go for other things. Then if you can't control the PPH, you have to do blood transfusions. And if you can't control further, you have to go for obstetric hysterectomy. If she lost a lot of blood, she should be going to ICU. And then macrosomia tend to have hypoglycemia and other complication. Or if baby had a shoulder dystocia during delivery, there should be neonatal intensive care support as well as a pediatrician. So these are the requirements. Consultant obstetrician-led unit with operation theatre and blood bank, 24-hour access. Never forget to say that, right? Because the hospital where I work, we have blood bank and theatre only until 4 p.m. right? So this kind of mother should deliver in a 24 access place, right? And then consultant pediatrician or neonatologist with neonatal intensive care support. These facilities should be available the place of delivery where this mother going to deliver, right? Okay. Then don't forget about the interpartum management and delivery. So what are the specific things in the interpartum management on this mother? Routine things you have to say, like autogram maintenance, pain relief, fetal surveillance. Those are routine things, right? But don't forget to say those things. Apart from that, any specific things? Macrosomic baby, GDM on insulin. You almost finish your professorial appointment. That's what Dr. Gihan said to me. What are specific things you are going to tell to the examiner? If she's GDM, do we need to monitor her blood sugars during labor? Yes or no? I'm not getting even yes answer.
Yes, sir.
Yes, sir.
How frequently?
Hourly, sir.
Yes, this mother hourly, right? If you're GDM on diet, then you are going for 4-hourly monitoring, right? Okay, blood sugar assessment, fine. What else? Anything else? What are the complications you're going to anticipate in this kind of a baby going to during the delivery? You said it previously. So how are you going to counteract that particular problem?
Uterine atony due to overdistension.
That is not interpartum, that is postpartum. I'm still on the interpartum. You said me about the shoulder dystocia, right? Macrosomic babies, especially the babies with the mothers with diabetes, they are high risk of shoulder dystocia. Is that true or not? It's true. So how are we going to counteract that, or how are we going to be prepared during interpartum period? Who should be there?
Senior obstetrician.
Senior obstetrician.
Neonatologist. Neonatologist.
Okay. You should not say the senior obstetrician, you should say the experienced culture or experienced person or experience or senior or something like. Don't always say senior obstetrician because obstetrician always can't be inside the labor ward until she delivers. So always say the experience a culture should present at the time of delivery. Experience a culture, maybe it could be experience SHO or a senior registrar or a consultant, right? Something like that. So experience a culture should present at the time of delivery. And then fetal monitoring, don't forget, this fetus should be monitored continuously, right? Okay. So what is the immediate postpartum management? I got the answer previously. Can you say it again? Immediate postpartum management, what are the risks mother can have? Sorry. Yes, postpartum hemorrhage. So what are things you are going to do for the postpartum hemorrhage?
Active management of the third stage.
Okay, good. Anything else?
We can send the DT and get the blood ready.
Yes, that part we should mention during the interpartum management, which is good. Sorry, there's a train going nearby, which is good. We should say that during the interpartum management, right? Which is good, which I also missed. You should keep the blood ready, right? Anything else? You can give some prophylactic medications, right?
Oxytocin, 20 units of oxytocin.
Yes, you can start some infusions, oxytocin infusion, because there are no much side effects like ergometrine. So you can start some oxytocin infusion, prophylactic infusion, because macrosomic baby or distended uterus. So there's an increased risk of PPH, right? So PPH prophylaxis. Anything else? This one. Blood sugar monitoring of both mother and the baby, because GDM as well as the macrosomia both are increased risk factor for the baby to have hypoglycemia. So don't forget to mention that, right? And then newborn monitoring, and then you are going to tell about the long-term postpartum management and contraception. So what are the long-term postpartum management you are going to do in this particular mother?
About the dosage of the drugs, whether it needs lowering, and notifying the MOH in her area when she is discharged.
Very good.
Of her condition.
So how do you usually say mother on a insulin, metformin, and diet control, but it's GDM? How are you going to tail off the drugs? What we usually do is, if mother is only on diet control, we'll ask them to continue the diet control and do a fasting blood sugar in 6 weeks and meet her GP, or she can meet her obstetrician or someone like that. If mother is on metformin, only on metformin and diet, you can stop the metformin and ask her to stay on the diet control. Again, repeat the fasting blood sugar and a PPBS in 2 weeks time, something like that, and see what is the blood sugar values are fluctuating. Depending on that, you can either restart the metformin or you can wait for 6 weeks fasting blood sugar. And if mother is on a low dose insulin, you can stop the low dose insulin, continue the metformin, continue the diet control. In 2 weeks, reassess with the blood sugar series. and then see how her response. If mother is on a high dose, you're not going to stop it. You're going to half the dose and do a blood sugar series in the ward, day 1 or day 2, and see how she responds. Depending on that, you can either reduce or you can increase the insulin. And on discharge, depend on how she responds to the insulin and metformin. So that's how you're going to manage. And what else? So that's how you're going to alter the medication. Anything else you're going to say about the postpartum management? GDM mothers are increased risk of what? Future?
Type 2 diabetes.
Good. Then Maya, what are you going to do for them?
I want to have regular follow-up, medical, refer to the medical.
No. You're going to fill up all the medical clinic with GDM mothers.
Give dietary advices and advice on lifetime modification.
Very
If he is overweight,
very good. But one thing, you can ask her to get a fasting blood sugar annually, right? Get a fasting blood sugar annually, modification, lifestyle modification, exercise, and ask her to screen for type 2 diabetes next pregnancy also. If she goes for next pregnancy during the pre-pregnancy period, she should get screened specifically for that. Right? So those are things you're going to say, and contraception you can advise. Right? So always when you're going for a case, you have to go up to next delivery. Then only you will get full marks. Each component carries some kind of a mark. So sorry. Always go for the component and say something. If you one thing, you get mark regular to that thing. And use this. You are lucky because she says she presented increased life volume. So what are things you are going to ask in the history? Sleepy, hungry?
Booking visit, random blood sugar.
Again, you're going to ask about the previous past pregnancy and then booking visit, PPBS, OGTT. She was twice done OGT actually at 24 weeks, and again they repeated at 30 weeks, both are normal. So now your brain should deviate to other causes of polyhydramnios. So you should ask those causes in your history. So what are things you are going to ask?
So how did she know of the increase? So how did she know about the increased volume? Was it mentioned?
No, when you asking why you are admitted to the ward, she says, they says my volume around the baby is increased. That's how no mother says.
Yes.
So now you have to assess. This is lucky question, lucky presentation that she says at least increase like volume. Some mothers never says. Right?
So that means she must have done ultrasound. So what were the fixed ultrasound scan?
Mother says the baby's weight is normal according to the mother. But like almost things, I give you the findings later.
I want to know whether there's any abnormalities found in the 20th week anomaly scan.
Good question. Mother, and carefully any kind of gut atrasias. Yes. Good. Anything else?
How many fetuses?
How many feet? Okay. One baby. Why? How twins can get polyhydramnios?
In between.
Yeah. What other questions are going to ask from the mother?
Any placental anomaly, just placenta tumors.
Other doesn't. Anomaly scans also doesn't mention, it just mention about the placental location only. But it's good question.
How is a
Those things. Is there any specific reason to ask that?
as pregnancy intervention can cause
what? That I want the feedback from others. Any agree? Anyone disagree? TIH causes polyhydramnios. So the action will not help us, but generally pass those history, right?
Blood.
Right? In blood group and RH. Why you? What else?
During the pregnancy.
Okay, good. Mother says no. Why you are?
So for the previous parent ionization.
Okay. So the previous mother's blood, we know that you are negative and when RM something anomaly scan no, OGT is normal, she is positive, infection free, normal. On the examination, sympathy fundal height is 38 centimeters, she is 30. So it's more than period of femia. And the lie is lie. And she also has other features. Shiny straight abdomen, fluid stream, difficult to the fetal parts. Right? So, especially because we can't force for her because anomaly scan is normal, is normal, sugar. They're thinking it could be, right? Sometimes anomaly may be an when baby delivered, we identify the anomaly. In this case, we take the idiopathic exam. These two other causes you have to get. One thing is at least you're going to get in the exams, but always be prepared for that. Ask the question, show that you know the cause, right? So how are you going to manage this mother until delivery? She is the pigs. Grandma's mother. Any smart ideas? Haven't you met any mothers with polyhydramnios? Like idiopathic polyhydramnios? Okay, I'll tell the yeah. You are
You can reassure the mother.
Reassure. Okay. Yes. What else? Reassure what? What you are going to reassure? Okay. So reassure, always you have to reassure all the mothers that we are looking them after well, we will monitor the baby, we will monitor the mother's complication, and she will have a safe journey throughout the labor as well as the postpartum period. That's always reassurance. So what are the investigations you need? So we already know about the OGTT, we already know the infection screen, scan, so
if it's more than so it's
cut off. Right, good. Okay.
And estimated fetal is near, so it's normal.
So it's right. So these are Hydramnios only, right? And in normal weight, right? Treatments, any treatment for idiopathic polyhydramnios? Treatment?
You can remove some amount of cycle.
When we are going to remove? Always are like anything else? So not all mothers, only on selective mothers who's having symptoms due to excessive live volume, we are going to do we are going to do amnio reduction. And have you heard about the indomethacin treatment? So tell me about that. What you know?
I have heard that it's you can give 25 milligram orally every 6 hours. It decrease in the amniotic fluid.
Okay, how it decrease? How it decrease? To reduce the fetal urine production, right? This indomethacin previously also used for prevent the preterm labor, as well as these polyhydramnios. We can use it up to 32 weeks, but after 32 weeks we don't use it. But why have mature ductal closure, right? So we don't use after 32 weeks. Even before 32 weeks, there are some arguments not use it because there are some complications. Renal function of the neonatal colitis, intraventricular. Because of that, it's a treatment, doubtful treatment before 32 weeks. After 3 weeks, we don't, right? Idiopathic Polyhydramnios.
Can deliver vaginal
Good.
before baby's sizes and the normal range.
Can you but should do an ultrasound scan, close the uterus, and assess the fetal if present, she can go ahead and deliver, right? Something like that. Okay. Usually we can wait up to 40 weeks, or see, sometimes we tend to induce because of these polyhydramnios. Usually 9 weeks. After 30 only we are inducing them. There's no indication. Again, I would say the same answer, right? But the same consult of unit OT and blood bank because polyhydramnios
Because overextension of the uterus means there's high risk of PPH.
Yeah. And why we need a pediatrician with new support?
There could be undiagnosed fetal anomaly.
Yes, cord collapse, and then emergency delivery. In that case, we need the continuous, as you said, diagnosed fetal anomaly, right? Very good. Interpartum management and delivery. Anything special you want to mention in the interpartum management and delivery?
Be more careful when doing artificial rupture membrane.
Yeah. So all the fluid will push down and the core can come out, baby can turn. So what is, we are going to do a control artificial rupture of membrane in polyhydramnios, right? Anything else? Right? We are going to read and like one the examination, and second thing is ultrasound scan. Ultrasound scan, right? Is it postpartum? also carries the same risk like large baby, postpartum hemorrhage, right? Postpartum safety, postpartum PPH, right? All patient of postpartum hemorrhage, right? All the causes, right? Long-term particular postpartum management plans, unless we had some anomalies, and
or is it difficult with polyhydramnios?
Difficult at the time. Second thing is always the chance they will rotate back, right? Sometimes what we do is we do the, like sometimes they kind of oblique, like we gradually rotate, we do the control area, keep the head on the pelvis, something like so what to do is you just reconfirm the presentation and light labor, and if you can do a version and do a control, is fine, go ahead. If you can't do a version, did you get the answer or you have the further doubt? Okay. Yes, about the two cases we discussed, because we are going ahead toward the MCQs. Any questions? You can type also. Shy to speak.
During AR, after?
Yes, during the AR, that's why there is one control AR. One thing the board prolapse, one thing can turn, third the sudden decompression plus very good. Any other questions?
How when you retrospectively due to the problem like renal,
Idiopathic polyhydramnios, they have a mild polyhydramnios. Usually we say AFI is between 25 to 30, right? The babies who are having these fetal anomalies, their polyhydramnios always it's associated with kind of a severe polyhydramnios, like AFI is more than 35 or something like that. So that is the one clue we are getting during our scans. If the polyhydramnios is like a mild and we can't find anything in the anomaly scan, we consider them as idiopathic. But if it is a severe, most of the time it is associated with some kind of anomaly. That is one clue we are getting. If you're asking about the percentages, no, I am unable to answer that part.
Thank you, sir.
Because I haven't read any data regarding that. There may be data, but I haven't read.
They don't need percentages.
Okay. Anything else? Any other questions? As I have given you, like always put into your obstetric case into a kind of a format, kind of a tick box system. So then it will be very easy to answer the obstetric and handle the obstetric case. Always divide and answer: treatment, investigations, interpartum management, postpartum management, contraception, and fetal complication, maternal complication. Rather than telling everything in a one row, always categorize it. And you can buy some time also while you are categorizing. When you are speaking in the examiner, if you say there are maternal and fetal complications, you have like few seconds to think to say. But if you are straight away going to say about the third degree, fourth degree tears, shoulder distortion, everything, it's a jumble. Examiner also feel like annoyed, and you have less time to think. So always categorize and answer.
Sir, can
Yes.
you define controlled ARM?
Yes, it's not a definition. I'll say how to do it, right? Usually we need 2 persons to do that, right? Experienced person should do the ARM. The one person should push the fundus little bit down and keep the head on the pelvis, right? And the other person put the 2 fingers in and use the left hand, do the ARM. Before the ARM, don't forget to feel the cord is around or not, because they can have cord presentation. So feel the cord, whether you can feel it or not. If no cord, do the ARM. Don't take your hand out. Keep your hand fixed inside and ask the person who's giving some bit of pressure on the tummy to release their hand slowly, right? They will release very gradually, slowly. You don't move your hand. And when they completely released, then you gradually take your fingers gradually out, right? That's what we say control ARM. You can release while, before you taking out your fingers, you can release little bit of lipo and gradually take your fingers out of the cervix and then out of the vagina. That's control ARM. I usually redo a V after I taking hand out. I redo a V to examine whether there's any cord or around the cervix or out. That's the control ARM. You need 2 persons, 1 person giving mild pressure on the tummy, 1 person is doing the ARM, and a person who's pushing the tummy, take the hand first out, and the other person gradually take their fingers out from the cervix with a gradual release of lipo. Haven't you seen anyone before, any control ARMs?
Seen
Okay.
ARMs.
But not control, right? You would have done it by now. Haven't you done ARMs?
Done, sir.
Okay, good. Because while we are in Peradine, we do ARMs, episiotomy, suturing, and everything. Do you have that 24-hour rotation labor board 1 week still?
Yes, sir.
Very good. Okay. Any other questions? We'll see anyone has typed. No, no one has typed. Okay, so shall we move to the MCQs? Okay, this is a true-false type, right? Which of the following are causes for large fundus than POA? So now we have discussed it. You can tell me. A, fetal infection. True or false? Sleepy, hungry. Our participants also a little bit going down. Previously it's 104, now it's 89. True. Okay, good. So what are the infections? Can cause polyhydramnios. Torch infections, right? Okay. B, maternal anemia. True or false? False. Good. If the question mentioned as fetal anemia, then it is true.
True.
Good. Then RH immunization. They can cause hydroxy and polyhydramnios. Yes. Routine atresia.
True, sir.
Good. Indomethacin treatment.
False.
Yes, they can cause oligohydramnios if we treated for a normal baby, right? Okay, very good. So we have 3 answers correct and 2 answers are false. B and E is false, right? Okay. Second question. Regarding macrosomia. A, estimated fetal weight more than 75th centile considered as macrosomic. True or false?
False.
False. What is the cutoff value?
90th centile.
90th centile, right? Or more than 4 kilos on delivery, right? Both definitions are valid. PPH is a known complication. It's very easy, as we have already discussed these cases. It's true. Multiparity is a risk factor. True or false?
True, sir.
Good. Prophylactic C-section is advised if estimated fetal weight is more than 4 kilo. True or false?
False.
False. You always have to go with the guidelines and standards in MCQs, definitely, right? In clinical case also, you should know what is the guideline, what is the practical situation in Sri Lanka, right? So you have to say the standard thing and you have to show the examiner that you know it is not practical in Sri Lanka or it is not assessed or it's studied in Sri Lankan population. So we usually practice this, something like that you can say in the clinical case. But in the MCQs, it's always standard answers, right? So if more than 4.5 kilos in a GDM or chronic diabetes mothers, Caesar. If more than 5 kilos in a non-diabetic mother, C-section. That is the prophylactic C-section for the macrosomic baby, right? And E, increase the risk of shoulder dystocia in diabetic mother than non-diabetic counterparts. True or false?
False.
It's not, so you mean it doesn't increase. So you say risk is same.
Yes, sir.
Any other question, answers, or anyone agrees or disagrees?
True, sir. It's an independent risk factor, diabetes mellitus.
Why? Can you explain, like, physiologically why there are increased risk of shoulder dystocia? Because in diabetes, the fat deposition on the baby in diabetic mothers, they are mainly on the upper part of their bodies, mainly the shoulders and the tummy. So if you compare the head to chest ratio and head to abdomen ratio, chest to head ratio, abdomen to head ratio, both are high in GDM babies. That means their fat deposition are more in the shoulders and the tummy. So definitely they will have higher risk of shoulder dystocia. That's the reason we are doing Caesar for the 4.5 kilo baby on GDM babies and other babies 5 kilos. That is the reason. So it increases the shoulder dystocia. It's an independent risk factor, right? So it is a true. Okay, we'll go for third. Regarding polyhydramnios, define as deepest vertical pool more than 7 centimeters. True or false? Anyone know what is deepest vertical pool and their cutoff values? It is another method of measurement of amniotic. Sorry? Can you say it again?
So this is false.
False. So what is the cutoff value?
Around 8, I think.
They're not around 8, it's 8, right?
11.
Sorry? What is the cutoff value?
11.
Not 11, it's 8, right? So deepest vertical pool is, we are in AS5 amniotic fluid index. What we do is we usually measure the amniotic fluid volume in all 4 quadrants, right? In deepest vertical pool, we look at the all 4 quadrants and see where the deepest one and only measure the deepest pocket. Actually, it has proven it is better than AS5. Like it says the same finding it will find, but less interventions than AS5. So it's very easy because we don't need to measure 4 quadrants. The same results are coming and less intervention. So the values are 2 to 8, between 2 to 8 normal range. If it is less than 2, we say oligohydramnios. If more than 8, we say polyhydramnios, right? So just know about that also. And the B, severe polyhydramnios has a higher association with fetal anomalies. I already said that answer, no? So it's true again. Increase the risk of cord prolapse. Again, true. And then should consider induction of labor between 39 to 40 weeks on diabetic mothers. True or false?
If well controlled, it is true. But I did 37 to 40.
Sorry, you are saying 37 to 40 is a big gap, no? You can't give that answer. If you give that answer to the examiner, he will be annoyed. 37 to 40 means 3 weeks, which is most important 3 weeks, and you can either deliver 37 plus 1 or 39 plus 6. So some examiners will scold you if you say 37 to 40. No.
It depends on the control. So
control wise, they haven't mentioned anything about MCQ. So you can't ask other details.
Yes, sir. So maybe true, sir.
True. Okay. So in true false, don't answer if you know all 3 upper ones are correct. Don't go for the maybe ones. Right? You will get negative marks, no? Right? So what there are 2 factors we are thinking, or we are taking into account when we are going to decide the time of delivery in diabetes mothers. One thing is the, as I said previously, diabetic control. And second thing is the effect to the fetus, right? So in here, we don't know anything about the control, but already fetus is affected. So are we going to wait until 39 weeks? Answer is no, right? So answer is you should deliver same like mother who has a poor control. It should be between 37 to 39, or sometimes we do deliver earlier. Like if a macrosomic baby, 4.5 kilos or something like that by 35 weeks, we never wait until 37 weeks because baby can die. Even though however we try to control the blood sugars, sometimes they are not getting controlled. So sometimes we deliver earlier than 37 weeks, right? But never after 39 weeks. If polyhydramnios there, you have to deliver before 39 weeks, definitely, right? If there's a macrosomia, you have to deliver before 39 weeks in GDM or chronic diabetes mothers, right? So always take into both parameters. One thing is the blood sugar control. Second thing is the Fetal complication. If fetal complication are there, definitely you need to deliver before 39 weeks. I would say I would deliver between 37 to 39 weeks. Or if they want to further shorten the time period, I would say I would deliver between 37 to 38 weeks. Right? So this one is wrong. But for the idiopathic polyhydramnios who don't have diabetes, yes, this answer is a true answer. All right? Okay. Last one. Does not increase the risk of cesarean section. If you think about the complication of the polyhydramnios, you can answer this question. We already discussed.
False.
Does not increase the risk of. So you are saying it increase the risk of cesarean section. Why?
Uterine atony after.
Atony. Even normal delivery you can have atony. You can have atony even during the after season. So atony is kind of a postpartum thing.
Abnormal and cord presentation.
Cord presentation is one. Abnormal eye second is good, and also cord prolapse. And they also tend to have a lack of progression also, right? So yes, it increases the risk of cesarean section, polyhydramnios, right? Okay. And then we'll go to the question. SBA, single best answer, right? Which of the following is not a cause for, sorry, it's not, should be of, it should be for polyhydramnios, cause of polyhydramnios. Which of the following is not a cause of polyhydramnios? Anencephaly,
It is a cause of polyhydramnios.
it is a cause of polyhydramnios. So you are not going to tick it, right? Always when you are doing a MCQs, you always underline the most important words in the question. Never read the answers without reading the question, right? So in here, not is the most important, and then cause for polyhydramnios, right? So don't forget the not, right? So okay, anencephaly is a cause, so I'm not going to tick it. Twin pregnancy, again it is a cause. 22 transfusion, polyhydramnios, it's a cause, so we are not going to tick it. Posterior urethral valve,
False. Because it's posterior urethral cause oligohydramnios.
very good. So it is not a cause for polyhydramnios. So it's a, this is one we are going to tick it, right? But don't forget to look at the other two also always, right? Sometimes there may be contradictory answers. So tracheoesophageal fistula again causes saline difficulties, and you know gestation diabetes mellitus, right? It causes the polyhydramnios. So its answer is C, right? Usually you will get less MCQs and SBS on these large babies and polyhydramnios as a like whole, but in other questions, you will get a one stem or two stem with related to this large for gestation age statement. But purely getting is chance is very less. I try to find some from the internet also and some other books. It's very difficult to find purely causes for the large for gestation age or something like that. Right? Okay, I think I have finished my presentation. Again, questions. Any questions? Okay, if you don't have any questions now, you can always email your questions to me. I will try to answer you when I am not busy, right? This is my email address. You can answer. And these are the references I use for you. First thing is the 10 teachers. So read that book, cover to cover. And then if you want, you can read a little bit of Green Top and Nice Guidelines. If you want to go for a first class or a gold medal or something like that. And read Sri Lankan guidelines. Sri Lankan guidelines are important. You should know Sri Lankan guidelines. Who is this?
Morgan.
Anyone know about him? Very good. What he did? What do you know about him?
He fought for the rights of the African Americans, equality.
Very good. Right. So this is one of his readings, which is applicable to us also in this modern era. All right. Okay, so this concludes my lecture. So how many?
On behalf of all the students, I want to thank you for spending your valuable time, sir, for around 2 hours, when you would have done something more fun during this time. So it was very interactive session, and it helped us remember all the things that we learned during the appointments. And I think the way you discuss the case, this topic under the case as a case discussion in the end as well, and the MCQs also helped us reinvigorate our knowledge on these topics. So thank you very much for this, and I also want to thank PeMSAA for giving us this valuable opportunity to interact with great clinicians like you, sir. So thank you very much, sir.
Okay. So you all guys, how many days you for your final exams? How many months?
So it's in March.
March. So 6 more months. Okay. So final year, study well, study hard, use your maximum to study. I know there are third years and fourth years. So for them, enjoy the university, go around the university, do all the work in the university, all the fun things, because university is the best place you will remember forever in your life, especially the PeMSAA. So don't miss any opportunities. Final years, if they miss those opportunities, when you finish your exams, you can apply for the demonstrators, go into the department, and then you can again enjoy your life in the PeMSAA. Right? And always, my email address is there. If you want my slides, I can forward to the Dr. Gihan, and through him you can get the slides, and you can send you any question